Research only matters if it actually changes what happens in practice. We generate a lot of evidence in healthcare, but far less of it reaches routine care. This session is about that gap, and more importantly, how to close it. Hello, this is Dr. Ahmed Al-Jaishi, and in this module, we're talking about the knowledge to action framework. There's a well-known statistic that it takes about 17 years for research to reach routine care. That's not a single delay, it's a series of missed connections along the way. Evidence often gets produced, but then it doesn't get adopted, isn't implemented well, or isn't sustained. The KTA framework helps us unpack that journey. It shows us where things can break down and what needs to happen at each stage to move knowledge into action. Knowledge translation is an active process that helps evidence get understood, used, and sustained in practice. In the knowledge to action framework, there are two connected parts. The first is knowledge creation, which sits at the center. This is where raw evidence is refined into more usable forms, moving from primary studies to synthesis and then to knowledge tools or products. The second is the action cycle, which surrounds knowledge creation and focuses on what is needed for that knowledge to be implemented in practice. These two parts are interdependent. Knowledge creation gives us something useful to apply, and the action cycle helps move it into care, programs, or policy. At the same time, what we learn during implementation can raise new questions and feedback into future knowledge creation. You can think of knowledge creation as a funnel that turns raw evidence into something usable. At the top is knowledge inquiry, where primary research generates new evidence from studies and observations. This is followed by knowledge synthesis, where findings are combined through systematic reviews and summaries to give a clearer overall picture. At the bottom are knowledge tools and products, such as guidelines, decision aids, and care pathways. These are designed to help people apply the evidence in practice. As knowledge moves through each stage, it becomes more focused, more practical, and easier to use. In pragmatic trials, the evidence may be strong, but that does not guarantee it will be used in routine care. A common challenge is the action cycle, meaning it is not enough to show that an intervention works. We also need to understand how to adapt it to routine care settings, address barriers to uptake, monitor whether it is being used as intended, and sustain change over time. The rest of the discussion focuses on the action part of the KTA framework. The action cycle outlines what needs to happen to move evidence into practice. It starts by identifying a problem and selecting relevant knowledge. That knowledge is then adapted to the local context, followed by assessing barriers and facilitators to its use. Based on that, you select and implement strategies to support uptake. Next, you monitor how the knowledge is being used and evaluate outcomes to understand impact. Finally, the focus shifts to sustaining that use over time. These phases are not linear. They are dynamic, iterative, and often overlap in practice. You may move back and forth between steps as new challenges or insights emerge. The goal is not to follow a strict sequence, but to ensure that evidence is effectively integrated into routine care settings. As we go through the action framework, we'll use the PINCER trial to show how each step can be applied in practice. So, briefly, the PINCER trial asked whether pharmacist-led IT support could reduce hazardous prescribing better than simple feedback alone. It was a pragmatic, cluster randomized trial in UK primary care settings, involving 72 practices and over 480,000 patients. The intervention used computer searches to identify patients at risk, followed by pharmacist-led feedback, education, and ongoing support. Practices then took action to correct existing issues and prevent future errors. We'll use this example to help ground the action cycle in a real-world trial context. Action Phase 1 focuses on identifying the need. Every knowledge translation effort should start with a clearly defined problem or gap between current practice and best evidence. First, define the gap. What is happening now, and what should be happening based on the evidence? Next, explain why it matters. What are the consequences for patients, providers, or the health system if this gap is not addressed? Then, identify who is affected. This includes patients, clinicians, and other partners who experience the impact of the problem. Finally, decide what outcomes matter. What changes would indicate that the problem has been addressed? A clear and specific problem definition sets the direction for everything that follows in the action cycle. Applying this to the PINCER trial, the problem was that prescribing errors in general practice were a preventable cause of harm, including hospital admissions and death. Hazardous prescribing was also common, contributing to a meaningful share of admissions. The no-do gap was not about a lack of evidence. Electronic records could already identify patients at risk. The issue was that many practices were not systematically finding these patients or acting on those risks. Simple feedback alone was not enough to change practice. So the gap was between what could be done and what was actually happening in routine care. Once the problem and gap are clear, the next step is to select the right knowledge to address it. In many cases, that knowledge may come from existing guidelines, programs, or care pathways. But if you have just completed a pragmatic trial, that trial can serve as a strong evidence base. The key is to ensure the trial results are applied to the same local context, meaning the trial intervention is implemented as tested. Applying this to the PINCER trial, the team drew on systematic reviews and prior research to identify drugs and situations most linked to serious medication errors. From there, they narrowed the focus to high-risk prescribing and poor monitoring that could be reliably detected using routine primary care data and acted on. That knowledge was then translated into practical tools, including prescribing safety indicators and computer searches that practices could use directly. Selecting the right knowledge is not done in isolation and requires early input from partners. Partners help define the problem, confirm priorities, and ensure the selected knowledge fits the real-world setting. This includes patients and families who experience the outcomes, clinicians who deliver care, and managers or administrators who shape workflows and resources. Policymakers may influence broader adoption, and community partners can help ensure the approach is appropriate and acceptable in different contexts. Engaging these groups early improves the relevance and usability of both the knowledge and the implementation plan. It also increases the likelihood that the intervention will be adopted and sustained in practice. Applying this to the PINCER trial, partner engagement was built into both the intervention and its wider rollout. At the practice level, GPs, practice nurses, practice managers, reception staff, and pharmacists worked together to review search results and plan changes. Each group played a role in identifying risks and acting on them within routine care. For scale-up, a broader network was involved. CCGs, or clinical commissioning groups, and AHSNs, or academic health science networks, supported regional adoption. Primus, a primary care data and quality improvement organization based at the University of Nottingham, helped deliver the IT tools and wider implementation support. Building on stakeholder input, the next step is to adapt the knowledge to the local context. Evidence cannot be applied the same way in every setting because it needs to fit how care is delivered in practice. This includes available resources, staffing, and infrastructure. It also means aligning with existing workflows and processes. Other factors matter as well, such as culture, language, and local policies or regulations. Population needs and priorities can also influence how the intervention should be applied. The goal is to keep the core elements of the evidence the same, while making it workable in the setting where it will be used. Applying this to the PINCER trial, the intervention was adapted as it was used in real settings. Within each practice, teams reviewed patient records, developed action plans, invited patients for follow-up, and made changes to local safety processes. These steps were shaped by how each practice worked and the resources available. In some cases, the issue extended beyond a single practice. One example was dual antiplatelet therapy, where treatment may have been started in hospital and then continued in primary care. In that situation, the general practice could identify the risk, but fixing it required coordination with the acute trust, because the original prescribing decision and specialist oversight sat outside the practice. The key point is that the same evidence was applied differently, depending on where the problem originated and who controlled the workflow. The next step is to identify what might help or hinder its use. Barriers and facilitators exist at multiple levels. At the individual level, this includes knowledge, skills, beliefs, and motivation. At the organizational level, factors like leadership, staffing, time, and available resources play a role. At the system level, policies, funding, and how care is delivered can either support or limit implementation. These factors often interact. A barrier at one level can affect others. If you do not take the time to understand this context, your implementation strategy may not address the real issues. Sometimes what might look like a simple issue is often a symptom. For example, lack of time may reflect staffing shortages, competing demands, or workflows that make the new process harder than the old one. Lack of knowledge may point to gaps in training, limited access to decision support, or information presented in ways that are not easy to use. Resistance to change may reflect real concerns about safety, fit, or workload that were not addressed early on. If you only respond to the surface issue, your strategy is unlikely to work. Focusing on the underlying cause helps you design solutions that are more likely to be effective in practice. For the PINCER trial, facilitators included alignment with national policy, such as QOF, or the Quality and Outcomes Framework. The QOF is a pay-for-performance program used in UK primary care. It also aligned with broader National Health Service patient safety priorities, as well as peer influence and visibility among clinicians. Protected time for teams in a growing pharmacist workforce also supported implementation. At the same time, there were important barriers, such as limited training capacity, especially during the COVID-19 pandemic. Funding uncertainty and organizational changes affected delivery, and momentum dropped when PINCER was no longer tied to Quality and Outcomes Framework incentives. There were also practical challenges. Running searches and using Chart Online, a web-based audit and feedback platform used to upload data, track prescribing safety indicators, and compare performance over time, required technical support. The work depended on trained staff with time to act. and some risks originated outside primary care, which made them harder to address. These factors shaped how the intervention was implemented in practice. Building on those facilitators and barriers, the next step is to choose strategies that directly address them. There is no single approach that works in every setting. Some strategies focus on dissemination, such as presentations, summaries, or digital campaigns. These help raise awareness and ensure people understand the evidence. Others focus on implementation, which is where most of the work happens. This includes training, audit and feedback, engaging local champions, redesigning workflows, and using decision support tools. Strategies should match the problem, the audience, and the specific barriers identified. For example, if time and workflow are issues, then process redesign and role changes matter more than additional information. The next step is to tailor the strategy to the audience and the setting. Start by identifying who needs the message. Different groups, such as clinicians, administrators, patients, and policymakers, will need different information from the same evidence. Next, consider what they care about. This includes the outcomes, priorities, and pressures that shape their decisions. Then, think about who they trust. Uptake is more likely when the message comes from credible sources, such as peers or respected leaders. Finally, identify what support they need. This may include tools, training, or changes to workflows. For the PINCER trial, the team used different strategies depending on the goal. For dissemination, they focused on raising awareness. This included academic publications, feedback reports, summaries, and educational materials. These approaches help people understand the problem and the evidence. For implementation, the focus was on changing practice. Pharmacists provided targeted education, worked with teams to analyze specific problems, and supported action planning. Practices also held meetings and follow-up sessions to review progress. Training was a key part of this approach. By 2020, over 1,100 pharmacists had been trained through online tools and structured learning sessions. The point is that awareness alone was not enough. The strategy combined dissemination with practical support to drive change in routine care. Once a strategy is tailored to the audience and setting, the next step is to prepare for implementation. This means turning the plan into something that can be carried out. First, start by defining clear roles and responsibilities so tasks and accountability are understood. Second, ensure there are enough staff and resources to support the work, because without capacity, implementation will stall or fail. Third, ensure leadership commitment is visible and supports the work as a priority. Fourth, provide training and ongoing support so teams have the skills and tools they need. And finally, define progress indicators. These help track whether the intervention is being used as intended and allow for adjustments during implementation. In short, a strong plan needs to be operational before it can succeed in practice. With implementation, be sure to monitor use and evaluate outcomes. Monitoring focuses on whether the knowledge is actually being used as intended. This includes tracking uptake across settings and providers, fidelity to the practice being implemented, how widely it is reaching the target population, and any new barriers that emerge during rollout. Evaluation focuses on whether the change is making a difference. This includes clinical outcomes, provider behavior, patient experience, and system performance. These two phases work together. Monitoring helps show what is happening during implementation, while evaluation helps show whether it is achieving the intended effect. For the PINCER trial, monitoring and evaluation were built into the implementation approach. For monitoring, practices uploaded baseline and follow-up data to Chart Online. Chart Online is a web-based audit and feedback platform that allows practices to run standardized searches, track prescribing safety indicators over time, and compare their performance. This tool allowed prescribing safety indicators to be rerun over time and made it possible to track change across time and practices. Access to local and national comparison data also helped identify variation and target further action. For evaluation, the original trial showed significant reductions in several important prescribing errors. During scale-up in the East Midlands, prescribing errors were reduced by 16.7% at 6 months and remained 15.3% lower at 12 months. By April 2020, 2,430 practices had uploaded baseline data covering over 23 million patient records. Monitoring and evaluation tell you if something works. Sustainability is about making sure it keeps working. Change often fades once initial funding, attention, or project teams step back. That is why sustainability needs to be planned early. This means building ownership by identifying champions and embedding accountability into existing roles. It also requires securing long-term resources, including staffing and infrastructure. Equally important is integrating the change into routine systems, such as policies, workflows, onboarding, and performance processes, so it becomes part of usual care rather than an add-on. Finally, continue tracking performance over time. Ongoing monitoring helps detect drift, reinforce what is working, and show continued value. Sustained knowledge use is what turns a successful intervention into lasting impact. Again, bringing this back to the PINCER trial, sustainability was built in from the start. First, the repeat measurement was key. Practices reran prescribing indicators regularly, creating an ongoing feedback loop for review and correction. Second, workforce development supported continuity. Training models, online resources, and shared learning helped maintain skills over time. Third, policy and structure mattered. Longer-term funding, national support, and integration into routine systems helped embed the intervention beyond the trial. Finally, ownership and accountability were distributed. By embedding processes into everyday workflows, responsibility for sustaining change sat within practices, not the project team. With that, I want to thank you for watching. If you found this content helpful, consider liking the video and subscribing to the channel. You can also explore additional resources through the links on this slide, or scan the QR code to access the full training platform.